to Dr. Shreyas Ramamurthy, who's going to present some challenging case discussions, and I would definitely want Supriya, Mahipal and Ramamurthy to add their thoughts as to how they could have been managed differently or their thoughts on it. We have about 15 minutes, so let's cover it.
So, thank you so much, and good afternoon, everyone. So, I'll just be taking you all through a few case scenarios, most of them which are more common, but have something unusual in them, which we may face commonly in our day-to-day practice, and how we can go about handling them. So, this is first patient is a 24-year-old male patient who had undergone PRK elsewhere for 4 diopter sphere in Kerala, and had a progressive decline in vision for the last 2 months in the left eye. And he had when he presented to us, his best corrected visual acuity had dropped down to 618. And this was the clinical picture, where you can see he had a significant reticulate scarring in this region, where you see a typical of a post-PRK haze, along with a hypertrophic epithelium and a hypertrophic scar. Now, we have to differentiate this from a routine post-PRK central haze. This is something which is a little unusual, something where this is an exuberant healing tendency which a patient may have. And you can see here that this is the way the underlying stroma itself, it's not very deep, although it looks large. It's just primarily because of the epithelial hypertrophy that it is appearing heaped up, and only the very limited portion of the anterior stroma is involved. If it was a little deeper, a PTK would not be sufficient, and we would probably have to go in for an anterior lamellar keratoplasty. But in this situation, I decided to go ahead with a superficial keratectomy followed by PTK. This is video from a different patient, but it's just to discuss what we have done. Is essentially important to loosen the epithelium using either alcohol or paracaine, and then you can scrape off the epithelium. Now, when you're doing it, in all the other areas where the scarring is not involved, it will come off in a single layer. But here you will see that it keeps coming in multiple layers. And actually, you can even sometimes hold the edge of it and peel it off entirely, or you can just scrape. And as you can see here in this region, it's coming out in layers. And this is essentially the heaped up portion of the epithelium and the subtle anterior stromal scarring, which can be removed. Once this is done, to smoothen the bed, we can do a PTK. But now we have to apply a mitomycin C for a much longer period, for about 2 minutes or so, to ensure that this kind of scarring does not recur again. Now, this is a likelihood that this is a patient who has a keloid tendency. This is the first surgery. Is a 24-year-old. This is the first surgery he has ever undergone. So we don't really have history of keloids as such in this patient. But this kind of exuberant scarring is less likely to happen. Now, in such cases, again, you have to anticipate a high degree of recurrence. This is early post-operative period. You can see that the scarring has been completely removed. This is just epithelial stippling. Epithelium is taking a little longer to remove, heal. You have to leave the BCL on for a much longer time. The patient also was prone to multiple episodes of surface inflammation, had to be kept on steroids for a much longer time, a little stronger steroids, to ensure that the amount of heaping doesn't come back. And you can see that the AIOC2024 is looking fairly smooth. The anterior corneal curvature is restored. But still, the patient had a subtle scarring which did alter and induce a significant astigmatism. And while the best spectacle corrected visual acuity did improve, because of the higher degree of anisometropia, patient was not very comfortable with the glasses and required a contact lens trial, with which the patient's vision improved to 6.6. But it still continues that even despite the initial management, over a period of time, slowly the scar can come back, and then it remains stable. But the idea behind this entire thing is, what was originally heaped up and elevated has now become a flat, subtle, uniform scar. And this is still amenable to contact lenses as well as spectacles, which the patient was intolerant to earlier. We could not even do a contact lens fitting in the first place. So there will be tendency for recurrence, but if managed well, we can end up with a less exuberant healing, which will allow us to manage the patient. So these are the questions which come to mind, steps to avoid this complication, any different approach in handling this which we have done, and what can we do to prevent recurrence. Any thoughts, any inputs?
No, now the amount of cylinder seems to have gone up post lifting, but the BCVA has improved. So do we presume that over a period of time with the scarring and flattening out, the astigmatism may reduce? Was the patient happy after what was done?
So essentially, the preoperatively also I didn't put up the topography pictures, but it was a very irregular cornea. So it's just that we could not really refract the patient properly when the scar was there. And now with the subtle scarring, we are getting a better reflex, and the central reflex is clearer, and we are able to neutralize the refraction better. But it's not that the procedure has induced an astigmatism, but it is the subtle scarring, and you can see that typical paracentral scar. It's almost like an artificial intax which has been done, which is causing in that area specific flattening and steepening along the opposite axis and inducing a.
Did he have a lot of dryness? What could have been the reason to have such an inflammatory response in this eye?
So he kept having waves of surface inflammation, kept having episodes of congestion. So this is something, that's why in the early post-op, maybe even in the first time when he underwent the PRK, if it had been managed adequately, if he had given sufficiently long period of steroids, not removing the BCL till the epithelium is completely stabilized, UV protection, all this would help in reducing the amount of scarring. And of course, mitomycin C kept for a much longer period in the first instance. However, we really don't know which patients may go in for such keloid tendencies.
Can you go on to your next case?
Yeah, sure. So it can be done, but see, at the end of the day, it may work in a condition like OSSN, whereas with this kind of, where the procedure is what is causing activation of fibroblasts, and it is not an ongoing condition, it is the initial management which becomes key. Once it is stabilized, generally it does not develop progressive scarring. It's the initial delay in healing, initial inflammation, which leads on to the haze and then progressive scarring. Yeah. So the aim of PTK here is different. It is not just to remove the scar. Removing the scar was majority done by the superficial keratectomy itself. It is to smoothen the bed that we are doing a PTK. So decentering the PTK may not really help in smoothening the bed itself. If it is very irregular, we have to even use a little bit of masking agent, put a little drop of CMC so that it fills in the troughs which are there in the epithelium, and then we can go ahead and do a PTK which will result in a much more smoother and uniform bed. And this, having a uniform bed, is also important for proper epithelialization to take place and for no hypertrophy to happen. There must have been something in the initial episode, somewhere, some problem, which led to, you can see even while I was scraping, there was a small divot in the stroma. And that improper healing or irregular surface is what has led to an excessive scarring also.
Can we?
So yeah, so up to 100 micron, generally we could do a PTK. Generally beyond that, I would go in for a ALK, DALK if it is really significant, but manual ALK or a femtosecond assisted ALK also works reasonably well. Yes, there will still be some interface irregularity. It will take some time for the BCVA to improve and settle down, but at least you don't have the suture related issues which a DAL can have, which makes it a much longer recovery. And so I'll run through these two cases quickly. They're aligned with each other. This is a 26-year-old female, stable power for the last 5 years since the age of 21. High myopia, but anisometropia. The right eye is a moderate myopia, left eye being a high myope. The corneal topography was normal, slightly thinner corneas, where we decided to go ahead with the phakic IOL. Patient had a good outcome following the toric phakic IOL initially. After 3 years, presented with a new onset of this kind of myopia, or regression or progression, as you would call it. Now, it has become a routine practice to take biometric measurements for patients both pre-op and post-operatively. And you can see that in this eye, the right eye and the left eye has actually the axial length has progressed. Even the eye with a reasonably moderate myopia has also progressed from 24.7 to 25.5, and this from 27.02 to 27.63. So this 0.8 and 0.6 is what has really induced the myopia, and there has actually been an increase in axial length. I'll just add with this case also, because both are interlinked together. Now this is again a patient with anisometropia. The right eye was a relatively low myope with some cylinder, and the left eye was a moderate myopia with cylinder. Patient, again, normal topography, slightly thinner corneas, in their mid-20s. The first patient was 27, the second patient was 24. 4 years after the IPCL, the patient was maintaining stable refraction with a very small cylindrical residual, which was there right from day one. The patient was happy with the vision. 1 year later, patient presented with a significant shift in myopia. And the only incident that had happened during that 1 year was that she had a pregnancy and she had delivered a child, and this was 4 months after the delivery of the child. And this was a unilateral myopia, and this was unilateral myopia in the eye which had the lower myopia. It was just 1.5 to begin with, and she had a significant increase. And as you can see here with the axial length, it has increased from 23.82 to 25 in the right eye, whereas the left eye is almost the same, the eye with the higher myope. So more and more as we go on, we are seeing more of these cases. I mean, our counseling for phakic used to be that with LASIK you may get back a power, but with phakic generally you won't get back a power unless they were extremely high myopes. We expect some myopia progression in staphylomatous eyes, where the eyeball growth continues to happen, the staphyloma continues to increase, and some myopia may happen. But even in these mild to moderate myopes, we are seeing patients with a progression myopia. Was pregnancy a risk factor in axial length elongation? We always knew that some curvatural myopia, biomechanical weakening can happen, but the topography was stable, but the axial length prolonged. So I've presented 2 cases, but we have more of these cases happening nowadays, and something for us to ponder over even in our initial counseling and planning.
Thank you, Shreyas. That was a wonderful talk. I think the youngsters were the best in this. And thank you very, very much for all of you who were there for this course. I'm sure you would have learned something and gained something more. Thank you very much.